The second part of the today's journal club is basically on fetal medicine, and the Ashita has covered very well the culture media part and the culture system, the one of the part of IVF lab, and I will be covering a journal club from ISWAG. A published report, should a cell-free DNA testing be used in pregnancy with increased fetal nuchal translucency? What are these things? ये होता क्या है? I will explain first, then I will go into this chapter. There are two things. One is cell-free DNA and another is anti-scan. What are these things? How they are interrelated? Why we are doing? What this paper is creating the importance about? Most of the time, the gynecologist, obstetrician, in their patients who are in early part of the pregnancy, we are concerned about Down syndrome. But Down syndrome is not the only syndrome which affects the baby. The other structural defects or other subchromosomal or some microscopic chromosomal defect which are not seen in karyotype or microscope might affect the baby also. How to identify them early? So these are the methods which screens the baby for whether there is any suspicion of Down syndrome. So how you screen the baby, more is the robust the technique, more is reliable the technique, the chances of the positive screening test coming as true positive will be more. In this regard, there are, in the first trimester, this is called first trimester screening. The first trimester screening which most of the gynecologists or fetal medicine expert, they do are, one is double marker and anti-scan. With this, the age of the mother is added. With this, any history of the other birth defects are added. So it gives a screening result out of how many, one out of how many there are chances of having Down syndrome or trisomy 18, trisomy 13 or XY. This is the usual method we do. Here another thing comes in between, that is cell-free DNA. The cell-free DNA is a fetal cell from, actually it is not a fetal cell, it is from the placenta which is supplying the baby. This placenta has few cells which are coming into maternal circulation, and these cells are not intact cells, so they have a free DNA which is circulating in mother with mother's own DNA. So there is cell-free DNA, one is maternal cell-free DNA and one is fetal cell-free DNA. This fetal cell-free DNA fraction is very nearer to actual baby. So if we get this report, then there are more chances that without touching the baby and with mother's blood, we can get the report. But is it the actual report? This paper deals with that. If there is problem with the anti-scan, Now, what is the problem with the anti-scan? Here, the baby is scanned and it is head, body, and this is the neck. Here it is the neck where there is a skin fold which is having some liquid inside. This part is called nuchal translucency. This is taken from the Down syndrome original discoverer, that there are extra skin tag in the babies, in the newborn Down syndrome babies, where there is a skin tag. So the Kyprios group, the Fetal Medicine Foundation group, they studied and found that this nuchal translucency is actually related with chances of Down syndrome. But is it the only thing which is related with increased translucency is related with Down syndrome? We will discuss it. Now, if there is increase in nuchal translucency, that means you are expecting or suspecting this baby with the Down syndrome, that is trisomy 21. With this, can you go for an abortion? No. Then you need a diagnostic test. In between this and diagnostic test, I told about cell-free DNA from the baby, that is fetal cell-free DNA. So you will say that if we are getting cell-free DNA from the fetus, then if we do this test, then it should be a diagnostic test, but it is not. It is again a screening test. Now, if this comes positive, this comes high risk, this nuchal translucency is in millimeter and it is along with the length of the baby, that is called CRL. This CRL is actually gestational age by ultrasound. So with a particular gestational age, there is a nuchal translucency and we plot a chart and make it normal or abnormal with a percentile. I am not going into that detail. But this paper, with this background, I am coming to this paper, should cell-free DNA be used in pregnancy with increased nuchal translucency? Is it a valid test? The introduction of cell-free DNA as a screening test for fetal aneuploidy, that is either trisomy 21 or 2018 or 13, question the utility of components of first trimester combined screening such as nuchal translucency measurement. I already told about that, the combined screening first trimester. The fetus with increased translucency thickness are increased risk of chromosomal and cardiac anomalies. So they have added another important thing with the chromosomal anomaly. There is adding the baby might be having a heart defects also. Increased NT is a marker for cardiac and other structural anomaly, microdeletion syndrome, and single gene disorder that cannot be detected by cell-free DNA. That means you can detect some of the aneuploidy, but other things which creates an ultrasound reported increased nuchal translucency is not always due to trisomy or aneuploidy. So there might be some other things hidden, but if you take a decision with nuchal translucency and take a decision with cell-free DNA, if cell-free DNA comes euploid, then there might be something hidden inside the chromosome that is called microdeletion syndrome or single gene disorder. There is an uncertainty of the role of cell-free DNA in the fetus with increased NT. This is the introductory part about this paper. The aim of the study, objective of the study was to evaluate which genetic and structural anomalies would be missed if only cell-free DNA testing was performed in fetus with nuchal translucency, that is 99th percentile. This percentile means with the gestational age and the particular NT thickness at the time of sonography, we should plot a chart. If it is 99th percentile, more than that, in order to assess the suitability of the cell-free DNA. So with every gestational age, there will be a different measurement of 99th percentile thickness. So it is, NT is never called a normal. It is always related with the gestational age and with the plotting. So method is retrospective, study population 226 fetuses with NT with 99th percentile at 11 to 14 weeks gestation. All pregnancies were offered chorionic villus sample, that is a diagnostic test. Irrespective of obtained risk, this combined risk quantitative fluorescent chain, that is what we do nowadays at QF-PCR, was performed. If normal, then we always do a chromosomal microarray. The result of chromosome, this quantitative PCR, which gives 5-probe analysis, rapid, which is within 24 hours to 48 hours, and chromosomal microarray were evaluated to determine the rate of chromosomal or some microscopic anomalies that would theoretically be missed by cell-free DNA. It has been taken that the cell-free DNA cannot detect all these things. The primary outcome was to compare the theoretical performance of two cell-free DNA testing models, targeted cell-free DNA involving 13, 18 and 21, and extended cell-free DNA, which we call it advanced, with involving 13, 18, 21 and sex chromosome, with that of cytogenetic testing and ultrasound assessment in the first and second or third trimester. That means the patient has undergone confirmatory test along with this, with the cytogenetics, that is a chromosomal analysis and ultrasound assessment. Results were included in 226 pregnancies, 198 singleton and 28 twin, in which at least one fetus has a NT of 99th percentile. That means at that gestational age or at that crown rump length, what the NT has been measured when plotted against the normal, it crosses the 99th percentile limit. So QF-PCR revealed typical aneuploidy that would be detectable by both targeted and extended cell-free analysis in 68%, 30% fetus. CMA revealed 3 clinically relevant atypical chromosomal anomalies and 5 submicroscopic pathogenic variants. In 2 fetuses with a normal CMA result, persistence of increased NT prompted testing for diagnosis of very important syndrome, that is Noonan syndrome, in the second trimester using stored fetal DNA. Now, this Noonan syndrome is a rasopathy which is not possible by cell-free DNA or even by QF-PCR or sometimes even by chromosomal microarray. But this rasopathy, Noonan syndrome, will cause increase in NT. So results was 37 out of 84, 37.2% genetic anomalies identified in the study population. Out of 84, 68 would be detectable by targeted cell-free DNA, 74 would be detectable by extended cell-free. This means that 19%, that is 16 out of 84 and 11.9% of the fetuses with increased NT and genetic anomaly detectable prenatally would have been missed if the targeted and extended respectively cell-free DNA testing were used. So these are the results, and what perinatal outcome. There are multiple termination of pregnancy, and there is an abnormal ultrasound findings also. I'm not going into that detail. The major fetal malformation detected in first and second or third trimester fetuses with NT more than 99, and the QF-PCR and CMA reports. So the result is, out of 142 fetus, no genetic abnormalities, with no genetic anomalies identified. Early anomaly scan and early fetal echocardiography identified structural defect in 15 fetuses, resulting in 1 miscarriage, 8 terminations of pregnancy, 3 intrauterine fetal demise, and 3 live births. Of the 127 remaining fetus with normal first trimester genetic testing and imaging findings, second trimester imaging fetal echocardiogram plus anomaly scan identified structural anomalies in 19. The remaining fetuses with increased NT in the first trimester has a normal perinatal outcome. Very important statement. In fetuses with increased NT in the first trimester, conventional cell-free DNA testing does not appear to be a valuable test, since 12 to 19% of the genetic abnormalities would be missed by such a test, accounting to 4.4 to 7.1% of the studied fetus. That means the cell-free DNA is more specific about the gross chromosomal defect, not subchromosomal defect even. And within the chromosome, there are multiple genes. You cannot get the genetic information by cell-free DNA today. But there are tests. Cell-free DNA is good for cross chromosomal anomaly aneuploidy, that is especially for 21. But the positive predictive value is still not very good, so it is a screening test. The first trimester anomaly scan was able to identify additional structural anomaly, 11% of euploid fetus with enlarged NT. So the more the percentile of NT, that is nuchal translucency thickness, more are the chances of fetal anomaly. So we should have a good ultrasound. If possible, do a first trimester fetal echocardiography. Second trimester follow-up ultrasound assessment allowed identification of structural anomaly in further 8.4%. First trimester, sometimes we can miss it because it is not easy to do by every sonologist to do a very good, it requires a very high-end machine and very, very important man behind the machine. So this is a discussion and these are the conclusion. Cell-free DNA testing misses 12 to 19% of genetic anomalies in fetuses with NT more than 99th percentile. First trimester ultrasound can identify a major structural anomaly in 11% of the fetuses with NT more than 99th centile and no genetic anomaly. So whenever there is a high NT, better do a good ultrasound, but cell-free DNA is not the answer for getting answers why NT is raised. Thank you very much, and this is discussion points. The same thing, does this paper change the present clinical practice and should we propose the clinical management protocol extended to high-risk pregnancy? Do we need to study better, define the sensitivity of extended cell-free DNA testing? Do the results of this study add information to updated counseling of high-risk pregnancies? Thank you very much for patient listening, and this, I found this paper was very important for every gynecologist and every sonologist who are doing fetal medicine practice. And with this cell-free DNA, whenever we do, be careful about its sensitivity and positive predictive value. Because if you don't do this, then it is a disruptive test which creates problem with the decision making by the gynecologist, the obstetrician, fetal medicine expert, and the patient. Because patient always wants a simple, easy to do test. Even companies, they reach to their home, take the blood and do the non-invasive prenatal testing. Because it is non-invasive prenatal testing, it sounds like that you are testing the actual baby by mother's blood. It is there. There are many advantages, but if you find something which is problem in nuchal translucency thickness or during anti-scan, cell-free DNA testing is not the answer, because you might miss a lot of things. So it is better to go for diagnostic test. And those whosoever are listening to me, even we do a diagnostic test, my choice is that it is not the only aneuploidy which matters. It matters what is inside the chromosome, submicroscopic deletion and duplication. You can only do submicroscopic deletion duplication by chromosomal microarray. Otherwise, if you only do a FISH or your PCR5 probe, you might miss, even there might be no aneuploidy gross chromosomal anomaly. All chromosomes are looking normal and they are 46. But if there are subchromosomal deletion and duplication, the baby might be missing a lot of genes which are very important for its life. Whenever you do, it is recommended by American College of Obstetrics and Gynecology that whenever you do a invasive test, always do chromosomal microarray along with that, because it is like searching the jungle for only tigers, there might not be any tigers, but there are other animals which might attack you. So it is better to search the jungle for everything. When you enter into the jungle, then the cross which can attack you should be seen. There are people who are doing the amniocentesis and all. It might be little bit cheaper, but you might, because every time you cannot enter into the amniotic cavity. So whenever you get a fetal DNA, exact fetal DNA from amniotic cavity, or if you are doing Korean villus sampling as a diagnostic test, always do aneuploidy test. What I prefer, and I will always order my lab, do a rapid 5 chromosome analysis. Along with that, do a karyotyping also, because it takes time. So gross anomaly of the chromosomes of other, and some microscopic, that is molecular karyotyping, molecular cytogenetics, that is chromosomal microarray. Thank you very much for patient listening. We will meet again in our next journal club. Thank you very much.